Thank you. Now, again, I can't see David on our attendance list. So, David, if you are there, please could you put a question in the Q&A so that I can find out your name that you're registered under, and I can then promote you to panelist. In the meantime, again, I think a short discussion with our gathered expert panel. I would agree with those conclusions. Charlie, from an American point of view, we always think of America as being quite a litigious place to practice medicine. Do you find that you have to send the Dupuytrens for documentation? Do you have to send it to the path lab, despite the cost, the wasted effort, etc.?
Yeah, according to the pathologists' lobby, no, the hospitals have policies regarding this type of thing. They're very explicit, and so depending, I think all the hospitals that I've done procedures in have required specimens to be sent for pathology, and so with routine Dupuytren surgery of excision of tissue. Having said that, I would agree entirely with the speaker's findings, and I don't know if it's really from a litigious point of view. I've just run across it as hospital policy. There are reports of sarcomas being confused with Dupuytren, but in all of those papers, confused with Dupuytren and also with Letterhose. There are scattered reports, but in those papers that have pictures, to my eye, there wasn't a clear picture of Dupuytren or Letterhose. It looked as though something was off, and so it would have been entirely appropriate to send a specimen. And I think so. I would agree entirely with the recommendations of this paper.
Yeah, and I think David did say in the conclusions quite clearly that if there's anything atypical, then you should probably send it for pathologic examination. I work in a regional sarcoma center as well, and my colleagues who regularly treat sarcoma have seen cases exactly like that, where there's been Dupuytren's not sent, recurrent Dupuytren still not sent, and so on, and eventually a sarcoma is diagnosed. But again, on review of these cases, they don't. At initial presentation, you sort of think there's something not right for them being Dupuytrens. Keith Denkler, another view from the States, has said a well-needed study on the routine or the lack of need for routine pathology on Dupuytren's fasciectomies. So I think we've got some concurrence there. Duca would say when preventative treatments become available, pathology might be of added value to evaluate disease stage, for example. At the moment, we don't really, and she's also said at the moment, we don't really send those cases for pathology. But of course, if we do come up with a disease-modifying treatment, then we may need biopsies. Charlie, Paul, what do you think of that?
Yeah, we don't take biopsies because we are afraid that we may cause the disease that is in a quiet state to become active. But yeah, we are still working on that, and we have recently completed studies where we try to correlate the ultrasound finding with pathology, which is very interesting. So the question is whether you need a pathology. Having said all that, I routinely send my tissue still to pathology. For one, we are a training hospital, and I also want the trainee pathologist to be able to get a clue about what Dupuytren's is. And I get the most funny reports, I must admit. Whereas I am convinced that I have Dupuytren's, and they say, no, there's no Dupuytren's. But I also secretly, in that way, harvest tissue for future scientific work, maybe. Obviously, if we go and use it, we will ask permission in retrospect to use it. But so those are my reasons to still send it in.
But the the routine pathology of Dupuytren, there is no pathognomonic finding of Dupuytren in routine pathology, unless you're doing electron microscopy or some immunohistochemistry. The pathologist can't tell the difference between Dupuytren and an immature scar or a mature scar. So that's the other issue. You can play a little game of sending it off to the pathologist and giving different diagnoses than Dupuytren and see if it comes back consistent with healing scar or something like that. So
Yes.
I agree it's overused, and I'm glad to have this.
I totally agree with what David Gorman has written there. Paraffin-embedded DD tissues are valuable for research, so it would be a shame to lose that source of information.
For the future, yeah.
Yeah, although I think particularly in restricted budget healthcare environments, we need to be careful about what we do, because every time we send something for routine pathology, we're denying someone else treatment for some other condition as well. So my personal view is that if you are going to want these tissues for research, we should be collecting them for research under a research budget and under research ethics approval, or IRB approval, as you would say in the States.
Yeah, I in general I agree, but luckily in Holland, although we are restricted too, we are not as restricted as you seem to be in the UK.
Okay, I think on that note, the only thing it remains for me to do is to announce the winner of the best free paper. They will get a certificate and they will get a cash prize. So thank you once again to our sponsors, FIDIA, for sponsoring the best free paper award. And congratulations to Devuka Broekstra, who is the unanimous winner.
And I didn't vote.
And I didn't vote either, but the other members of the committee did vote. And Devuka, well done. You're the unanimous winner. So congratulations, and we will be in touch with your certificate and your prize very shortly. Thank you for all the attendees, and thanks once again for the panelists. Don't forget to register for 2 weeks' time. We have a fantastic session all about radiotherapy, which I think is going to be really educational and really interesting to hear some experts outside of the surgical field talking about Dupuytren and Lederhoser. So we're really looking forward to that. Please do join us again, register for the webinar in 2 weeks' time. Thank you, everyone. Good night.
Thanks.
Good night. Bye-bye. Thank you.